Let's hit the ground running. In this explainer, we're diving straight into the exact biochemical matrices that dictate split-second, literal life-or-death clinical decisions. We're skipping the basics today, folks. We're zooming in entirely on granular physiological details and those really complex decision boundaries where the subtlest variables completely shift your management strategy. We're talking about mastering the razor-thin margins of clinical toxicology.
So picture this. You're in the bay, and an undifferentiated, completely chaotic presentation rolls through your doors. Pinpoint pupils, severe uncompensated metabolic acidosis, and fluctuating cardiac loops. What is your exact sequence of antidotes to prevent an iatrogenic death? Time is tissue here, and survival depends entirely on mastering the high-contrast diagnostic forks we're about to break down. You absolutely cannot just guess. Every single intervention you choose either neutralizes the poison or pushes the patient right over the edge. So let's map out these critical junctions.
Module 1. Cholinergic crises, organophosphates versus anticholinergic forks.
All right, here's our first critical junction. On one hand, you have organophosphates irreversibly inhibiting acetylcholinesterase. This means toxic levels of acetylcholine just pile up at the receptors, triggering those profound muscarinic effects. Think severe wheezing, massive salivation, pinpoint pupils, and nicotinic muscle fasciculations that lead straight to paralysis. On the flip side, anticholinergic agents competitively block those muscarinic receptors entirely. That leaves your patient, as the old saying goes, blind as a bat, mad as a hatter, red as a beet, hot as a hair, and dry as a bone. Understanding this exact receptor-level pathophysiology, it's absolutely crucial to prevent a fatal error in your antidote selection.
Now, the really crucial point here is the sequencing when you're dealing with an organophosphate exposure. You're faced with a choice architecture that forces a very specific order. Step 1, secure the airway. You must force immediate IV atropine, which is a competitive muscarinic antagonist, and you titrate that until the bronchial secretions literally clear up. But here's the catch. Atropine doesn't fix the underlying enzyme lock, and it doesn't touch the nicotinic muscle paralysis. That's exactly why Step 2, prelidoxime, or 2-PAM, has to be deployed concurrently or immediately following the atropine to actually go in and reactivate that acetylcholinesterase enzyme.
And honestly, this brilliantly illustrates the absolute physiological limit we're working against. Pralidoxime only works if you beat the clock. You have got to administer it before chemical aging bond stabilization occurs, which typically happens within a 24 to 48-hour window. If you miss that chemical aging window, that bond becomes permanent, and your patient remains permanently paralyzed. No way around it. Pure pralidoxime monotherapy or a simple bronchodilator trap will completely fail them. You must sequence correctly, and you have to do it rapidly.
Module 2. Toxic alcohols, metabolic breakdown, and the osmolar gap matrix.
Moving on to toxic alcohols. The sneaky challenge here is that the parent alcohols aren't actually what kill the patient, it's their metabolic breakdown products. Both of these lethal alcohols hijack the exact same enzyme, alcohol dehydrogenase, but their downstream destruction forks into two entirely different directions. Methanol metabolizes into formic acid, which specifically attacks the optic nerve, causing optic disc hyperemia and, ultimately, blindness. Ethylene glycol, on the other hand, metabolizes into oxalic acid. This binds with calcium to form these envelope-shaped crystals that literally shred the renal tubules, causing severe acute kidney injury and acute tubular necrosis.
I want you to burn this number into your retinas, greater than 10. This is the elevated osmolar gap threshold that dictates immediate, aggressive intervention.
Let's break down the math real quick. You take your measured serum osmolality and subtract the calculated osmolality, which, as a reminder, is 2 times the sodium plus BUN divided by 2.8 plus glucose divided by 18. If that equation leaves you with an osmolar gap greater than 10 and you've got a concurrent elevated anion gap metabolic acidosis, boom, you have just confirmed the presence of hidden, toxic, circulating, unmeasured anions. Basically, you found the ghost in the machine.
Once you spot that gap, you've crossed the diagnostic therapeutic red line. Step 1 is immediate ADH blockade with famotidine. This is a competitive inhibitor that stops the production of those toxic metabolites dead in their tracks. Step 2 is initiating emergent hemodialysis mapping. Why? Because if the pH has plummeted below 7.25, or if you're already seeing visual changes or acute kidney injury, famotidine just isn't enough anymore. At that point, you need to physically pull the acid out of the blood. Now listen up, because this is a massive error mitigation trap. If you suspect an ingestion and the gap is over 10, pull the trigger on famotidine. Do not, under any circumstances, wait for direct gas chromatography confirmation of the serum toxic alcohol levels.
That is a notoriously slow lab test. Waiting for that result while formic or oxalic acid is actively accumulating in your patient's tissues is a literal lethal delay. Treat the numbers you have right in front of you.
Module 3. Acetaminophen and salicylates, the kinetic elimination forks.
All right, here we encounter a bit of a paradigm shift. We're moving away from simply blocking enzymes and stepping into the realm of optimizing kinetic elimination. With acetaminophen or APP, toxicity is driven by the depletion of glutathione stores in the liver. This leaves its toxic metabolite, NAPQI, totally free to cause catastrophic centrilobular necrosis. On the flip side, salicylates, like aspirin, uncouple oxidative phosphorylation. This creates a profound systemic energy failure and a highly specific, totally chaotic, mixed acid-based arrangement.
Let's analyze this specific arterial blood gas. At first glance, a pH of 7.43 looks deceptively normal, right? But look closer at the partial pressure of CO2 at 22 and the bicarbonate at 13. This perfectly maps the dual pathology of salicylates. You've got a primary respiratory alkalosis from early central respiratory stimulation causing hyperventilation, and that is aggressively clashing with a primary, delayed anion gap metabolic acidosis driven by the uncoupling of the electron transport chain. If you only glance at the pH, you will completely miss the poisoning.
So how do we actually optimize elimination here? Well, for salicylates, it's all about the physics of ion trapping. You administer continuous IV sodium bicarbonate to alkalinize both the serum and the urine. What this does is transform the lipophilic salicylic acid into its ionized hydrophilic form. Once it's ionized, it gets trapped right there within the renal tubule lumens. You are completely shutting down its ability to passively diffuse back into the systemic circulation and the central nervous system. It's a real game changer.
Now, for acetaminophen, your kinetic bounding relies entirely on regenerating glutathione with N-acetylcysteine or NAC. Usually, we just plot a 4-hour level on the Rumack-Matthew nomogram. But here is the absolute hard boundary. If the ingestion time is unknown, or if more than 8 hours have elapsed and the patient is showing toxic signs, or say they ingested more than 7.5 grams total, you bypass the nomogram entirely. You initiate empiric IV NAC immediately without a second of hesitation to save that liver.
Module 4. Clinical Reconciliation and Disruptive Toxicology Traps.
Okay, we're bringing it all together now to reconcile these pathways against the traps that catch even seasoned clinicians completely off guard. First up, intubating a salicylate patient. Remember that ABG we just looked at? They are relying on extreme baseline compensatory hyperventilation just to survive. If you intubate them and set the mechanical ventilator to a standard rate, their PCO2 shoots up, precipitating rapid CNS death via worsening acidosis. You have to match their extreme minute ventilation. Second, never, and I mean never, utilize atropine expecting it to fix nicotinic neuromuscular junctions in organophosphate poisoning. It only works on muscarinic receptors. And third, administering activated charcoal past that 1 to 2 hour viable ingestion window. It's pretty much useless and just introduces a risk for lethal aspiration pneumonitis.
I also want to remind you of the absolute limits. When kinetic elimination, fluid resuscitation, and your antidotes fail, you've got to pull the trigger on emergent hemodialysis. The AEIOU mnemonic dictates this mandate. Severe acidosis, intractable electrolyte abnormalities, toxic ingestion, specifically our friends ethylene glycol, methanol, and severe salicylates, volume overload, and uremia. You have to know your backstops for sure.
Let's look at one final juxtaposition here. If you've got a comatose patient, you need to look at the peripherals. A TCA overdose will present with an anticholinergic toxidrome and a wide QRS complex tachycardia on the ECG. That patient needs sodium bicarbonate pushed immediately to overcome the sodium channel blockade. Conversely, an opioid overdose presents with meiosis, pinpoint pupils, and a profoundly depressed respiratory drive. That patient requires pure receptor antagonism with naloxone. It's the exact same comatose presentation, but with entirely different biochemical red lines.
This explainer has mapped out the absolute physiological limits and choice architectures of high-stakes toxicology. Every single decision you make at the bedside has to be grounded in these precise biochemical realities. So, I'll leave you with this provocative thought. When the next undifferentiated comatose patient rolls through your bay, will you sequence the right biochemical red lines, or will you fall into the trap? Keep studying, keep analyzing, and I'll see you in the next explainer.